So I'm going to move to the side here because I'm very short, and then I can actually see my slides.
Isn't Steelers and Detroit?
So I had to show my allegiances here for Super Bowl Sunday. Being from Michigan, we feel the Lions were robbed this year. We expected them to be in the Super Bowl. We're devastated, but there's always next year. And I'm originally from Pittsburgh, so I will forever be a Steelers fan. We had no Super Bowl aspirations this year with the Steelers, but there's always hope for the future. So today I'm going to talk about systemic therapy for HER2-positive metastatic breast cancer, specifically that has central nervous system involvement. So we'll start by just stating what I think many of us in this room who treat patients with breast cancer know, which is that CNS disease in HER2-positive metastatic breast cancer remains a major problem. So among patients that have HER2-positive metastatic disease, approximately 30 to 35% will ultimately develop metastases involving the CNS over the course of their disease. And you can also see that for patients who have CNS involvement of their cancer, it is a leading contributor to cause of death for these patients. So over 50% of patients with HER2-positive metastatic breast cancer that have CNS involvement will ultimately CNS disease be the cause of death. I want to also just highlight here in the NCCN guidelines, I'm going to highlight the therapies that we'll spend the majority of this talk discussing, which are those that have known activity in patients with CNS involvement. So this includes the so-called HER2 CLIMB regimen of tucatinib, trastuzumab, capecitabine. We'll also talk about lapatinib and neratinib, so agents that have been known about for some time and have CNS activity, although their role post-tucatinib is really unclear. We're going to talk about TDM1, trastuzumab emtansine, which again has been utilized for some time and we know has some CNS activity. And then finally, some of the more recent data involving trastuzumab deruxtecan, which was just referenced in the previous talk, clearly having CNS benefit. So I want to start just by talking about the regimen that we most commonly utilize in the first-line treatment for patients with HER2-positive metastatic breast cancer, and that's the combination of a taxane, trastuzumab, and pertuzumab, and this is in the context of the Cleopatra trial where that regimen was compared to taxane trastuzumab without pertuzumab. And one of the things you can see here by the Kaplan-Meier curves is that we know THP improves both progression-free and overall survival in patients with HER2-positive metastatic breast cancer over a taxane and trastuzumab. And it appears also that this regimen delays the onset of CNS disease as first site of progression. But it's very important, I think, to note that the incidence of CNS metastases is actually similar between the arms. And so we do not believe that the regimen of taxane, Herceptin, and Perjeta has CNS penetration. It just may be that since that is a good therapy for HER2-positive breast cancer, it at least delays onset of CNS metastatic disease. I next want to talk about the DESTINY-Breast03 clinical trial. So this is the clinical trial that took patients with HER2-positive metastatic breast cancer previously treated with a taxane and trastuzumab, and in a 1-to-1 randomized fashion, patients either received TDXD, trastuzumab deruxtecan, or TDM1, trastuzumab emtansine. Over 500 patients were included in this trial, and you can see that there is clearly a benefit for TDXD, trastuzumab deruxtecan, over trastuzumab emtansine with regards to progression-free survival. And what is important to note about this study is they looked at specifically the outcomes in patients who had CNS disease. So if you look at the Kaplan-Meier curve, patients that had brain metastases at baseline, you can see that TDXD definitely outperforms TDM1. And then if you look at the waterfall plots on the right, you'll see that the CNS overall response rate for trastuzumab deruxtecan is about 67.5%. There is still some benefit of TDM1, of course, in patients who have CNS disease, but the benefit is substantially smaller with a CNS overall response rate of 34.3%. So this data really helps us understand that trastuzumab deruxtecan is a good therapy for patients with CNS involvement and outperforms TDM1. There's also been data looking at pooled analyses from the DESTINY-Breast01, 02, and 03 studies with regards to CNS outcomes. And we just looked at DESTINY-Breast03, so I just want to highlight what the schemas were here for 01 and DESTINY-Breast02. So DESTINY-Breast01, really one of the first trials that we saw with this agent, which was patients HER2-positive metastatic disease previously treated with TDM1 in a single-arm phase 2 trial that received trastuzumab deruxtecan. And you can see in the waterfall plot, this was a heavily pretreated population that had really a profound response to this drug and was our sort of initial awareness that this was going to be a blockbuster in this disease. And then in DESTINY-Breast02, these are patients, again, heavily pretreated HER2-positive metastatic disease who were randomized in a 2-to-1 fashion to TDXD versus treatment of physician's choice. And again, as we look at the progression-free survival analysis, TDXD outperforms treatment of physician's choice. If you look at patients included in this pooled analysis that have either stable treated brain metastases or untreated active brain metastases, we can again see that no matter what the comparator, TDXD appears to outperform significantly the other agents. It's probably less pronounced in patients with stable treated brain metastases, but certainly in those with untreated active brain metastases at baseline, this is a superior agent to what the comparators were. And then finally, the DESTINY-Breast12 trial. This is looking at TDXD specifically in patients with stable or active brain metastases. So they had really a dedicated cohort in this study of patients with 157 of which had stable treated brain metastases, 106 of which had active brain metastases. And what we can see from this study is that the 12-month CNS PFS is really quite remarkable, whether you have stable brain mets or active brain mets, in the range of about 60 months, this is the percentage, at 12 months, that have not had progression. So about 60% of patients that have not had progression at 12 months, which is fairly remarkable. I want to now talk a little bit about the HER2 CLIMB trial. So this is another combination involving the tyrosine kinase inhibitor tucatinib that we know has good CNS penetration and activity. These were patients, again, heavily pretreated HER2-positive metastatic disease. They had all received prior trastuzumab, pertuzumab, and TDM1, and they were randomly assigned in a 2-to-1 fashion to tucatinib, capecitabine, plus trastuzumab, or capecitabine, trastuzumab, placebo. I've broken down the numbers there. Patients with brain metastases, you can see there's a good proportion of patients in these study that actually has active, untreated brain metastases. And again, as we look at overall survival, as well as specifically intracranial progression-free survival, there is a substantial benefit to this combination that includes tucatinib over trastuzumab plus capecitabine. With regards to systemic therapy beyond tucatinib and TDXD, there have been other studies involving tyrosine kinase inhibitors such as lapatinib, as well as neratinib. In the landscape trial, lapatinib was in combination with capecitabine, and in TBCRC 022, neratinib was also in combination with capecitabine. we can see that the overall CNS response rates were 65.9% or 49%, and the median PFS in these studies is approximately 5 months. But it's very important to note from these trials that the benefit of lapatinib or neratinib is really completely unknown after patients have had prior tucatinib. So the vast majority of patients that would be receiving these agents in fourth line and beyond settings, now with the HER2 CLIMB data being so compelling, will have received tucatinib. So some take-home points here about systemic therapy in patients with HER2-positive metastatic breast cancer that has CNS involvement. Taxane, Herceptin, Perjeta, the standard first-line systemic therapy, delays the onset of CNS disease, but does not have direct CNS activity. T-DXd and tucatinib, capecitabine, and trastuzumab combination have the most robust evidence supporting their use in patients with HER2-positive metastatic breast cancer with CNS involvement. I think many of us who treat these patients oftentimes are faced with the challenge of how we decide between these two regimens. There's of course never been a head-to-head comparison, and sometimes that decision is often made based upon toxicity profile of the agents, probably is arguably a little bit more experience with the HER2 CLIMB regimen just because that data was available to us first before the data such as the DESTINY-Breast12 study. And then again, lapatinib and neratinib also have CNS activity, but the benefit of these agents is not entirely well understood after patients have had prior tucatinib therapy. So I want to sort of wrap us up here with just some outstanding questions regarding the optimal care of patients with HER2-positive metastatic breast cancer that have CNS involvement. So for instance, how are patients with only CNS disease optimally managed? So I'll just give us an example to consider. A patient with one CNS lesion that has been resected or radiated and has no other systemic disease. Do you administer systemic therapy for that patient? I think this is something that we all, occasionally face in our clinic. I think given the compelling data with T-DXd and the HER2 CLIMB regimen, we certainly, I think, oftentimes err toward the side of caution and treating these patients. But it is challenging when they have no systemic disease and they're taking on a substantial amount of toxicity from this therapy. Second question, how are patients with both CNS and systemic metastases optimally managed in the first-line treatment setting? So an example here might be a patient with 2 CNS lesions, liver and bone metastases, diagnosed 2 years after completing adjuvant TDM1. Let's say they've had SRS to the CNS disease. Do you treat with taxane, Herceptin, Perjeta, or do you treat with an agent that optimally has CNS activity, such as T-DXd or tucatinib, cape, trastuzumab? Again, I think many of us are tempted and often do use the agents that have known CNS activity, but in the setting of the brain metastases being treated, this is an open question. Are there patients with asymptomatic small volume CNS disease where local therapy can actually be safely deferred? So an example would be a patient undergoes a brain MRI as a component of extent of disease evaluation after developing systemic progressive disease on first-line THP, and the MRI reveals 2 sub-centimeter brain metastases in the left temporal lobe. Could T-DXd or the HER2 CLIMB regimen be considered, and you could actually defer stereotactic radiosurgery? I think many of us, for patients that are asymptomatic, are now considering this. This has been incorporated into the ASCO guidelines, but of course this has to be done with caution, and there has to be really, really careful attention to follow up brain MRIs to ensure that they're having CNS response. And a final question I just want to pose is, should we be performing surveillance brain MRI on patients with HER2-positive metastatic breast cancer? Our guidelines currently do not mandate this. However, given that there's a 30% incidence of CNS involvement at some point over the disease course, I think many have advocated actually for this approach. So important considerations for the future. Both T-DXd and tucatinib are being studied in early stage HER2-positive breast cancer. Will this actually alter the incidence of CNS involvement of HER2-positive metastatic disease? I think that'll be something really interesting to see for the future. And then finally, what novel agents might be utilized for the treatment of HER2-positive metastatic disease that have CNS activity. I've listed 2 there that so far have some promising data. These are still in early phase clinical trials. We had both of these studies open at University of Michigan, and these are both tyrosine kinase inhibitors with, I think the main advantage of these studies will be, these will be largely in patients who have previously received TDXD and tucatinib, and so we will have a good sense of whether or not there's a role for subsequent TKI with CNS penetration, beyond the agents that we know have good activity. So thank you very much.
All right, thank you. I want to call out